Oh, perfect. Okay, let me get all the images out of the way over here. All right. Well, hi, everybody. My name's Holly Smith. I'm the UC San Diego Population Health Clinical Nurse Educator. And I wanted to give you like a quick about me. I've been a registered nurse for 27 years. I did a traditional program, 93 to 97, the University of Delaware, fighting blue hens, and completed my Master's of Science in Nursing Education in 2022 with Cal State University Channel Islands. But my experience has been starting with med surg, moving out to the emergency department, pre-K 3 through 12 of a private school, and then moving to college health setting to do advice nursing, infection control, administrative nursing supervisor, COVID clinical operations, and coming down here for population health nurse educator. So what I've always found about myself is I always moved on in my career, climbing the ladder, always making sure that I was helping the nurses that I was leaving behind and kind of growing to see more of having an impact at the individual level and the family level to really growing out to larger community system impacts. And so now I think of my impact is I'm not doing as much direct clinical care with patients, but I'm having an impact with nursing students, and they are going out and having that impact. So thank you for inviting me here today. I'm excited to tell you, how we got to Pop Health. I think I sit in a funny Zennial generation where I started on paper and migrated to electronic health records. And from that, what was going on in the background was really the Institutes of Medicine to Err is Human, Crossing the Quality Chasm, World Health, and there's this health equity came along, and then all the way up until 2021, where we have the future of nursing, really spelling out, patient community centered care, information system, quality, safety, systems thinking. So you're really at an exciting time in nursing where you're not there are more opportunities than being trained to just the bedside, and we're getting off this hamster wheel of kind of always, running through, well, in Delaware, Maryland at the time, 9 to 13 patients constantly on a hamster wheel and discharging them out and not even able to pause long enough to think about what they were going home to. And so what's really neat now is to see a lot of ways that through population health, you're able to target interventions and build out from like this framework that really looks to see how much you can impact more than just what, it's not the clinical stuff going on is really only accounting for 20% of how well patients and families, communities do. It's really what's going on outside of there. So there's a lot of room for ambulatory nursing, and that's where we see population health come in. Let me just put a little question in the chat. Oh, okay. Thank you for taking notes. And so, essentially just so we can distinguish population and public health. Public health is, what we're doing as a society, helping keep public safe. Population health is more, what is a system doing for their community or a defined population? So targeting interventions, using all avenues or resources to drive innovation and resources and innovations to drive kind of outcomes. All right, let me get off this boring slide. We'll skip over this. Essentially, you're going to get out of here and know key terms related to population health, be able to kind of talk about health promotion, protection, risk reduction strategies, and be able to have some health education and chronic disease management, within these frameworks. So what you see here is really, I think of us population health at UCSD as kind of in its, toddler phase. Really you had a shift in the landscape of healthcare reimbursement, moving from fee-for-service into value-based care or accountable care. And when you think of that, that means we're accountable for the care of a population. And how do we measure that? What are those metrics? And what tools do we have So in 2016, our population health started, and we have our way of doing it. But as I, quote my director of population health here, who's a fantastic nurse, if you've seen one population health, you have seen one population health. They're all different, but they really come from the same idea that, we are striving to address these needs along the lifespan and the continuum of care. And it reaches into the community setting. It increases your patient activation and engagement, and it's these targeted interventions. So today I'll kind of talk to you a little bit about how we do this here for us, but know that kind of in general, there's really opportunities across this nation to make things better. And so the space that I work in is kind of nestled in between the academic medical centers and then the primary specialty area, and then having access to kind of community resources. And where population health really works to churn a lot of the things that help, all pieces of that system. And primarily 80% of our work is done virtual. We have, and we'll go through kind of the programs we have here, how they're built and structured, what they do. But we do have one component where we send nurse practitioners out into the home, delivering care that's really kind of an extra wraparound service to complement their primary care provider. But this concept in general is really a team-based care approach. And that's mostly because we know, when well, I don't know about you all, but you go to see your provider in your ambulatory clinic and you probably have 3 to 5 minutes with this person. There's not a lot you can get done. So really, this team-based approach is what we were doing to kind of, how do we augment that capacity to help patients get the right care, the right place, the right time. And so it is a large team of us here. I think we're up to about 160 individuals. But this is just our leadership team. We'll talk a little bit about the programs. You see clinical quality, digital health, care connections, UCSD at home. And then my part in all of this is really being growing our reach out into local nursing schools and saying, hey, we understand, what the future of nursing is and what they need to learn. And this is how we do it and how we can demonstrate really you being able to graduate and go out into the workforce now with all of these extra skills that really nurses aren't picking up in the kind of the traditional clinical rotations for community and public health. So, all right, this is a fun part. So this is just how I like to think, like, you pretend you've gone to the Holly's Population Health Restaurant and I've given you a menu of services. So essentially that bottom tier, building that kind of strong foundation, this is probably 60% of our patients. They're walking well. They generally need help with scheduling follow-up appointments, annual wellness visits, cancer screenings, immunization. You're really thinking about kind of that primary space. And then this is where we have our clinical quality team. They're really working with a lot of analytics and kind of IT, kind of capturing quality data. And we'll talk about, how do you measure quality? What does that mean to the patient? So that's kind of our first program layer with clinical quality. Now we move up to digital health and disease management. I think that this is kind of our secondary space. And this is, the tools, what we do in these two layers, they're all of our patients that have said, hey, your UCSD is my primary care. These are available to them. So it gives them, options for how do we reach, how do we take care to you, particularly during the pandemic when many people were not leaving their homes to go in and get care. It was, sending out initially called Project 1000, $100 blood pressure cuffs sent out to vulnerable community members so that they could be checking their blood pressure at home, tying into their smart device, integrating to their Epic MyChart. And you had nurses coming in and we're looking at blood pressures. Are they doing it baseline? Are they urgent or are they critical? Do we need to be calling them or sending a nurse practitioner out to check on them? And so a lot of we do this with continuous blood glucose monitoring. We have mild to moderate depression, health text coaching tools. We've got a maternal outcomes blood pressure that we're doing. You'll see a lot of, as we work to scale, as a population changes from being 1 in 5 individuals 65 and over to now 1 in 4 by 2030. That's a lot of people, and they're living a lot longer with a lot more complex conditions because technology, medicines, or everything has improved. So our second tier, that digital health, really sits in that, yes, you have diabetes, hypertension, or something. We want to help you control that so we're not having poor outcomes. The top 2 are our rising risk or our highest risk. We'll talk a little bit about what how we identify risk for individuals and the services that are available for them. But we have a managed care population between our self-funded insurance plan and 13 commercial plans where we have our own in-house RNs, social workers, case managers, and that are connecting with patients post-discharge, transitions of care. And then the highest risk, that piece is about 5% of our population, and they're generally medically frail, older. They're nurse practitioners and MDs that we're sending out into the home, and they're not replacing the primary care provider for UCSD, but they have 45 to 90 minutes. And they have this shared collaboration of what's that kind of, how often do we need to be coming? We can ramp it up, ramp it down. You still see your primary care provider once a year, but here we have that option to do a little bit more. We're able to see, what does food look like in the house, food look like in the home? What resources do you have in the home? It's hard for you to have maybe it's hard, you're not able to drive, and it impacts your caregivers to take off work to get you to, can we come to your home, and what can we do for in your home? As far as physical assessments, medication reconciliation or titrating medications, we can do mobile labs, mobile EKG, mobile ultrasound. We can order durable medical equipment, order in home health, home PT, OT. We can do the physician's orders for life-sustaining treatment, go over that. So there's a lot. We can even direct admit into skilled nursing facilities when needed, or transfer into like a hospice service. So there's, it's just that extra layer. And so I enjoy kind of being a part of this program in its toddlerhood, I guess, and then look forward to seeing, what in long term will we see as it helps individuals. So when you think about, well, how do we decide who gets these resources? We only have so much. And so this is where you're starting to look at how do we risk stratify the individuals and then target them. So split out here, you see within Epic, health maintenance topics that we have. So these are some of our quality measures are located there. We have a social determinants of health wheel embedded in Epic, and there's screening questionnaires with all of those that are really helping us understand intimate partner violence, depression, medical transportation, food insecurity, smoking, things like that. And then using risk scores. So your longitudinal plan of care and snapshot, you're able to pull up general risk score, outpatients, your social determinants, end of life, a LACE score, like risk for readmission. And so I don't know if it'll hover here to open it up, but in general, you can think about risk score as, how old is this person? How many medications are they on? What does their psych history look like? Have they had kidney disease, heart disease, HIV? Are they, COPD? How many admissions have they had in the last 6 months, either emergency department or outpatient? So those are all ways we kind of pull in together to identify different heat maps to target. This is the staff we have. This is where we need to target our interventions. So maybe Nurse Holly at 49 years old, she doesn't have a problem taking time off from work, driving to an appointment, have any complex conditions, or have questions. I don't need to be targeted for this help. This is the best use of your resources, especially as our population increases. And there's lots of ways that our particular patients get access to us. We have internal referrals we do because we've recognized them from post-discharge, or their insurance plan has set them over, or they self-reported. But also our clinics are able to identify and offer these and offer these services to patients. And so sometimes, it's a lot to remember, and I don't expect you to remember it today, all of it, but just know, like, if you are ever anywhere and the hair's sticking up on the back of your neck, like you're worried about this patient, that's the, raising the question, hey, is this person eligible for Pop Health? What services do they have? How can they, what's on their menu that can help them? So within Epic, we talked about those quality measures. Some of these are listed here. They're generally, related to hypertension and diabetes, the scourges on the population, the global population, really. But they're, and this is not kind of, right now we're looking very green. This is a very old snapshot, but what does optimal diabetes care look like? It looks like you have your A1C every 3 to 6 months, because based on what the lab value is, you have your urine microalbumin, a comprehensive metabolic panel, you've had your diabetic foot screen, you've had your retinal eye exam. Are all those things done and up to date? Well, then you're meeting a quality metric. And so hypertension looks like, where's your blood pressure, and is it considered controlled? If it's uncontrolled, have you had a recheck in 4 weeks? And you're really looking to see that wider bridge of data that's going to help you guide their care and have those interventions sooner. You'll see things related to cancer screenings, immunizations, patient satisfaction, advanced caregiving. So, and then all of this really comes out of standard work for quality that is in Epic, and we'll use our dashboards and run reports to identify those patients. So in general, my little boasting slide we have every year, you can see, this only started in 2016, and our nurse practitioners only started going out in 2019, and that grew from 1 nurse practitioner, then to 3, and now we're up to like 10. And if we have time, I'll kind of show you the map, how they've kind of spread out. And, they generally are 150 patients are on their panel. So they see 4 or 5 patients a day, 5 days a week. And it's, and they definitely are, if you're interested, if you have a passion for geriatric care, that is definitely a way to, it's definitely a win for the patients. And everyone wants more healthy days at home. And no one actually, as much as you all want to go into the hospital, no one actually wants to be there as your patients. They'd rather be at home. But in general, we've saved $1 million with our Medicare accountable care savings from our 2nd year of service. We've had a 35% reduction in avoidable Medicare admissions from 2017 to 2023. Our patient satisfaction scores are always 93% or higher across all programs. And we're hitting that top 10% in annual quality by the audits from the Integrated Healthcare Association, California, out of 200 IPAs. So in general, we're just a huge piece of bringing care closer to where people live, and building out our programs. So I know we've talked, quality, digital health, disease management, care connections, UCSD at home, but I want to hone in on this care connections hub for you all, because my 4th year community health, public health case management students, they come generally up to 12 from local schools 5 days a week. And this is a program that they really help with supporting our patients. We'll generally move them across to learn about all programs and contribute to all of them, but this one the students really rave about. And so what this is really to help reduce avoidable admissions and support the patients at home. So, essentially one of your patients is going to the emergency room or the hospital, they're being discharged. They can expect an automated outreach call within 48 hours. If they respond to that and that they have a concern, just press a button. They're going to show up on our dashboard of patients to call back. And that helps us take from all of the hospitals, inpatients, and EDs, okay, these people need help. They've told us they need help. We've got to help them first. For those so we have a team of 8 RNs who are doing virtual work. They come into the office 1 day a week 4 days a week. They're working from home and they're talking with about 15 patients a day and helping with, and we'll talk about the things that they'll help with in a couple other slides. But essentially, where the students come into play is there's a large swath of patients who, and in this particular with discharges, whether we don't care if they're UCSD primary care or not, and we don't care who their insurance is. You are in our system and discharged. We have to understand, we take in to learn about primary care and different insurance plans, but looking at how can we help you. And so the students are really a second hit on all of those patients that didn't either answer the automated outreach call, or a nurse tried to call back and they still haven't reached them. So they get the opportunity to have a patient panel that they outreach. And it's generally, I've had about 39% of the students, or sorry, 39% of the patients that the students have on their list for outreach of the day are people who they assisted or needed some type of escalation to prevent a poor outcome. So it's just a great learning opportunity for the students. And I love that they carry back with them now that knowledge to go into bedside and know about, you have this impression of, well, I told you this is your discharge instruction and here's how things should be. And it shall be so. And then when you see this piece of it, you realize there's opportunities, or people they just want to get out of the hospital. They're going to nod and wave, and they really do have a lot of questions. So we can see data on what they need. But what's been really rewarding to me is I have a student who's with me this semester, and his critical care rotation's another day of the week. He actually was discharging a patient from critical care, and the nurse was being asked questions and didn't know the answers to them. And the student actually said, "Oh, I actually know." And he pulled out the discharge and was showing them and asking them, "And you'll need to do this. This is what to expect. And if this happens, if this happens." And so he ended up, the nurse said, "How do you know that?" And he told him about Pop Health, and we're all the same system. We're just so new. They made him go discharge 4 other patients on the floor that day. So I hope he ends up here. So this is what we were talking about with the heat map that's really giving us an idea of how do we target our interventions to those that need us. And so here you can see age, length of stay, general risk score, their healthy places index, and end of life scores, and it's all hover to discover, but that really gives us kind of how do we target our interventions, and then how do we think about, and this will be helpful for you. I would say take a screenshot of this if you could. You want to think about this is kind of from Project Boost. These things that happen. So as you're doing clinical care, or maybe moving out into case management, or taking this kind of the 8 Ps with you, like how many medications are they on? Are they high risk medications, anticoagulants? Your hypoglycemics, your narcotics that they're on, psychological issues, your principal diagnosis, physical limitations, poor health literacy, poor social support, poor hospitalization, poor palliative care. So your 8 Ps, when you're seeing these pop up, these are when you're thinking they could be a problem for this individual, and how do we mitigate that? How do we have them have more healthy days at home, or connect them to resources to help with that? But in general, kind of what you're seeing with we've built out this framework and all of our programming, you're seeing the nursing process. You've got your screening, your assessing, your planning, you're implementing, you're evaluating, you're just seeing a risk stratification. And now from that, let's follow up, transition them, evaluate, and then kind of keeping that circle going. And so all of this doesn't come from, keep it checking on time. I only know I got you till 2:45. All of this isn't something, we made up. It all really comes from evidence-based guidelines we use from MCG. And then because we have our clinical champions here, and a lot of work just to build these programs, and they're not finished. But if you're wanting to see just with this program, how this works, when you see what traditional readmission rates are at 12.8% as that large purple circle, when those post-discharge calls go out and there's escalations to a nurse, we see readmissions drop down to 11.7. From that, when we pull some into our transitions of care, those are the subset of high-risk patients, and they have a nurse that's outreaching them every week for up to 30 days following them. We look at them, we see the readmissions go down to 7.3. And so all of this means bad things aren't sending patients back into hospitals. Hopefully, we're decompressing some where there's, you feel like those days of like, it just never ends. I'm on this hamster wheel. They keep coming back. We're trying to help, handle this silver tsunami and wave of patient population that just keep coming back, leave some room for you. So we look at a lot of data and metrics. It's how we're doing. And, the Cypher outreach is really only started, I think, about July 2022. But you're seeing how many of those voice calls came out. So if you think, and we'll have one more slide that kind of has how many were reached and what those interventions were. But you're able to see how many calls went out in this month, how many were reached, how many of the patients you reached required an intervention to kind of show the impact. Here we can dice it down to, okay, how are we doing on our floors? So, let's just take, I don't know, here's 8 Hillcrest 10 East. There were 555 calls made. They reached 273 of them. 253 of the people reached required an intervention. And so as you look month to month or week to week or come, as we get moving and get better, where are we seeing, excellent, like the discharge instruction, this is all going well. Things are proceeding exactly. And where are things not going well? Where are there opportunities to make things better? In general, what we've seen, this kind of has a little 6-month, May to December. I think it was before the year ended, but it really gives you what are the things that were problems for the patients. And you can see, medications, whether they needed help with follow-up, problems attaining their medication. They were having new worrisome or worrisome symptoms. They had medical transportation issues, or maybe they don't have their discharge instructions. Maybe their discharge instructions are missing how to take care of their wound and no one told them. So it really gives you, what can we do better for the patient? So, and this is a patient success story from our assistant director of the Care Connections Hub, where the readmission was avoided. So just to give you this process of what it looks like, they were admitted to the hospital for laryngospasm, respiratory distress, poorly controlled type 2 diabetes, overnight stay. The son was at discharge, but we're kind of rushing the process. They went home discharged home on meds. So automated call goes out. The response was there was a medication issue. So they showed up on the dashboard. The RN came in, pulled up the dashboard, called this patient. The information they retrieved was how high that blood sugar was. And so the RN on the phone through MyChart back end was able to communicate with their PCP and get a medication change and a prescription bill and an education. This person was seen in the office 2 days later from that scheduling with an additional follow-up. That all happened, and had that not happened, this person would have been back in the emergency room. So I can give you, I've been here for 3.5 years. Probably 1,200 nursing students have come through here. And it's amazing the things that they identify or help with, or it's just been, or the things they discover that they're just completely shocked that these things happen. And I think, it's not just us, this is across the nation. So in general, as we try to talk with our outpatient nurses and our inpatient nurses, it's really, hey, there's an after visit summary, let them know this call's coming. If remind them to take that call. Think about those 8Ps when you're taking them home. There's always 211 if they need help with kind of social resources. And then, they see that purple Epic, you can see that population health eligible patients going to kind of clue you in there. So we try and give, and because we realized you also probably have clinical rotations here. at UCSD, how do you take this, or how do you apply it to wherever you end up? And so, you're starting to see, I'm familiar with UCS have a program, UCI is developing their program, Johns Hopkins Home's got a program, So you're seeing it happening. It's all deployed different ways, but they all come from that same population health framework. Like, target these interventions to the people that need them and build out this framework that helps drive, improve those outcomes. And that whole, you changed your, healthcare finance is now based on, can you prove quality? And no longer, we're moving away from fee for service, where you're having to, it essentially feels like when you have a fee for service system, it's incentivized by sickness. The sicker you are, the more money you make, the more tests you get, the more complex, that keeps everything. There's no incentive to keep you sick or get you healthy. Here, when you move over to value-based care, you're accountable, you're incentivizing what is quality to the patient, what is quality to the community, the system. How do we meet those metrics? How do we tie to to actually do a better job for individuals and communities? How am I doing on time? Not very good. I was supposed to go over hospice and palliative care, right?
No, yeah, you have a little bit of time. You're okay. You can keep going.
We'll blaze through this one. And so we have our 8Ps we talked about before. I'm just going to give you this. Essentially was a 76-year-old widow, Hispanic female smoker, 15-pack year, living unrelated housemates, comes to the ER, evaluation of dyspnea. You kind of get your history, meds, how many visits, inpatient or ED in the last, and I'll kind of slide you through this just so we can grab a little bit of hospice and palliative care. But essentially, we saw a lot of polypharmacy and anticoagulants. There was a history of depression. You saw cancer, stroke, and COPD. With hearing loss, physical deconditioning, so some risk for a fall, limited English proficiency, teach backs. How are we doing those? We addressing fiscal insecurity, food insecurity, transportation, 3 or more hospitalizations in less than 6 months. And then the question for palliative care, would death in less than a year surprise you for this individual? And how do we start those conversations? So in general, I'll kind of close it out here. Like the speed population health, just team-based care. You've got all those programs, but Care Connections Hub is really kind of all payer, all provider, PCP outreaching to see what we can do. And then, for you all as nursing students, think about the 8Ps. Even if you make yourself your own little badge buddy and you think about it before you're doing your discharge teaching. I will share slides with the Dr. Matson. But in general, I'm very into theories of adult learning. And many people probably don't want to hear me vomit out stuff for 45 minutes. So included, there is something I'm very, read, watch, or listen. The Advancing Population Health is Dr. Parag Agnihotri, the Chief Medical Officer, and he's really given a much more in-depth population health discussion. And then you've got a podcast and an article you can read to kind of solidify that information more. I think my other references, this was just, I wasn't sure if we'd have time, but our nurse practitioners in the home and the teams that they have and what they're doing, we're taking COVID vaccines out. And then just as we got started, you can see each of those zones are now where a nurse practitioner, that's their zone, and they're going in, visiting the patients, and the satisfaction rate is incredible. And I mean, we've got well more than 54 people over the age of 100 in the program. Just an idea what some of those tools look like, the bed scales, and sensors and glucometers and blood pressures that digitally integrate, and how we see that, and what kind of some of the health coaching and tools can look like depending on the type of monitoring, whether it's passive, active, and what they're actually doing. Some of the dashboards we use, and you'll see a lot of like your blood pressure critical on the second column. Those are, you can essentially see this is everyone that took their blood pressure today, who's in normal limits, who's elevated priority, and when a nurse comes in and runs this report first thing, the first thing she's doing is clicking on number 5. Those 5 patients pull up, calling them one by one by one by one. What's going on? How are you feeling? Have you eaten this morning? Have you taken med this morning? Are you and identifying. So sometimes it's a simple medication titration, connecting with the ambulatory pharmacist, backdooring them into specialty or ambulatory clinic. And sometimes it's, you need to go to the emergency room right now. And you potentially are kind of, saving a life that way. So a lot of fun stuff. We see a lot of how blood pressure enrollment in digital blood pressure monitoring, how it drives down blood pressure and just different tools. But, all right. I'm going to get out of this bit. Let me see if I can share my next screen. You're going to crack up because I've had 0 time to do my full out hospice palliative care. So I'm going to walk you through practical stuff that you would need to know. For now, though, do any of you have questions? Anything in the chat? We're good. You can always send me an email. I'm happy to, tell you more. I mean, occasionally I've had students come through and they're like, I actually don't want to do bedside nursing. This sounds awesome. So, it's every bit, with my 27 years, I will tell you, every single nurse and type of nurse is important. Legal, research, education, emergency ICU, public, school, all of it. You're all making a huge difference. And you can stay in a place forever. You can stay for 5 years. It's really taking care of yourself. So, okay. I think well, hold on. Let me see what screen I've got you on here. All right, that's the right one. Can do it. 7 minutes, Dr. Madsen. My father was 58 when he had a heart attack, and I thought I need to prepare myself for what I anticipated to be coming, given my grandfather was 66 and had an aortic aneurysm. My father also has type 2 diabetes, ignored it for probably 20 years. And so I got this book called Being Mortal. And for me, I read it so that I could kind of understand this is what this looks like. Because we've had such improvement in medicine and technology, and you're seeing people are living longer with complex conditions, but their quality of life is going down. And so I really wanted to be able to have these conversations with him about, when life is short and we don't know what that time is, what is important to you. And so I did all, I'm reading and I'm kind of trying to script out how I'm going to have these conversations with him. And it actually was my favorite aunt, 57 years old, that this ended up being just life-changing book for. And it was, she passed away from uterine cancer and sepsis after a 5-year, thought she was in remission and everything was fine. And then suddenly it was back, and we were dealing with PEs and all kinds of stuff. And this kind of led me to kind of a lot more interest in, why are we not talking about death? It is a part of life, and why does it have to be taboo? And so I definitely recommend this book if you haven't already read it. And then we're going to walk across my screen, and I'm going to very quickly, in 6 minutes, give you my top tools for hospice and palliative care, and invite you to just pick what you want as you move along, and to be helpful for you. So, got a pen and paper, write these down. You've got CAPC, the Center to Advance Palliative Care, and they offer 8 phenomenal modules. You can sign up for it for free, and it really gives you just a good starter kit to get going on these discussions. Hospice in a Minute is one of my favorite apps that really, and it's since the aunt died, now I've had Parkinson's disease with dementia, mother-in-law, and I'm having to deal with the other side of the family in complete denial. And I'm using these tools to have conversations about functional activities of daily living and a functional assessment status. And so Hospice in a Minute is a great app to help you guide a conversation through what someone can actually do and where they are. And when you look at these tools and these numbers, they lead you into, where is there an opportunity for end of life care? Where should that start? Can that look like as far as, and really, a lot of the country doesn't even understand like palliative care and hospice different. Like they're kind of got some pieces that weave in, but you always keep hope, but they're, they're so vital in making those, whatever that amount of time is important. Another one is another app you can put on your phone for free, Vital Talk. And this gives you, if you have to have a serious conversation or, you can click exactly what that is, and it will pop up sample language to help you have these conversations. Do know about the San Diego Coalition for Compassionate Care. They do have the Physician's Orders for Life-Sustaining Treatment webinars, free dementia webinars. There's just a great local organization. Another app I'll use is it's the iAGS, the iGeriatrics for the Geriatric Society app. It's got a lot of great stuff on it, and I particularly love the cultural considerations that they include. Very important as you're working on some of your schoolwork. You can use MD Calc. I pulled up just the Charlson Comorbidity Index. You can walk through it, and I'll just throw my dad under the bus here. So between 60 and 69, he's had MI, he has had CHF, he does not have peripheral vascular. Well, sorry, I'm gonna have to add yes now. Missing a limb, has not had a stroke, doesn't have dementia, doesn't have COPD, connective tissue, peptic ulcer, liver, I'd say mild, diabetes, yes. Let's see, kidneys are good. I've got to give them a win somewhere. And then it'll kind of give you, your index of what's the likelihood of survival in the next 10 years. So how do you use these tools for that information? You also want to learn about Hospice Nurse Julie. I have actually used this video when I really needed to get someone to the point of realizing what they were witnessing with their spouse is dying when they were in denial. And so these things are helpful. Others are your medical assistance in death and what that is and what that looks like state to state. This one's for California. It can look different in Oregon. The most recent hospice and palliative care, I brought in a hospice nurse and I also brought in a death doula, and we talked, kind of through all this and what this looks like. And then you have your California Physician Orders for Life-Sustaining Treatment and what that looks like. And then, if you're just a pediatric palliative care case audio or podcast listen to. All right, that was the fastest hospice and palliative care lecture I think I've ever given. But I hope you've got some just a couple tools here and there, a little bit at a time. Think about, mostly it's really looking at, it's immediately relevant to you, and then it begins to stick more. So if you're able to reflect back and how you would have managed things different, or thinking about moving forward, what you can anticipate, and just having these conversations and making, making it a safe place to talk about, what the end of life can look like. When you have that opportunity to make it the best of what someone would like it to be. And the most influential bit in that book they'll talk about kind of is, it was the decisions of, what was most important to the individual. And for one individual in this book, it was, could they watch football? Could they eat chocolate ice cream? And so every decision made through the medical situation, surgeries, interventions, will our father still be able to eat ice cream and watch football? Yes, then do it. Then do it, then do it, then do it. And when the family and significant others came together, and the first time they answered was no. If we do this, he will not be able to watch football. He will not be able to eat chocolate ice cream. They all were in unison agreement. No, we're done. Stop. And they were really honoring his wishes. And they had time to make that clear. So, yeah, that's kind of what that's been my starting point of conversations with people to go in this direction. So, let's see. I'm only 1 minute over.
So you're great. Thank you. If anyone has any